On to the lecture, and the
Thank
next
you.
talk is on a very interesting and a very emergency topic: VT storm in an intensive care, current approaches. Please show the CV slide. I'll request Dr. Aziz Khan to introduce Dr. Amit Vora. Dr. Aziz Khan, please.
Yeah. Good morning, everybody. Thank you, Dr. Manoria. Dr. Amit Vora does not require any introduction. All of us know him so well. He is the doyen of electrophysiology. He is a consultant cardiologist at HN Reliance Foundation, Biskendi Hospital and Lilavati Hospital. He has been partnered with Gracemark Cardiac Center and Arrhythmia Associate. He was a past president of Indian Heart Rhythm Society. He has been vice president of Indian Society of Electrocardiography. His special interest is electrocardiology, pacemaker implantation, RFA, and to his credit, he has more than 150 national and international publications, co-authored and written many chapters. He has been regular speakers to all meetings. He has been teaching all of us electrophysiology and arrhythmias. We always want to listen to him whenever he is there. So may I request Dr. Amit Vora to give his very important presentation on ventricular storm, which we face day to day in our ICU. Dr.
Thank you, Dr. Thank you, Dr. Khan, for those kind words. I'm going to share my screen and okay, I hope my slides are visible and I'm audible.
Yes.
Okay, so the ventricular tachycardia storm is what we are going to discuss about today. And the definition of a ventricular arrhythmic storm is that if you have a recurrent hemodynamically destabilizing ventricular tachycardia or fibrillation, which occurs 2 or more times in a 24-hour period requiring electric cardioversion or defibrillation, is defined as a ventricular arrhythmic storm. Now, currently you have many patients who are on with an ICD, and the ICD therapies happen recurrently. So with patients who have an ICD, 3 or more appropriate therapies are given for a ventricular tachycardia, which might be in the form of an anti-tachycardia pacing and or shocks within 24 hours, is considered as a VT storm. So this is a very challenging problem, and it needs to be addressed as rapidly as possible, because hemodynamic collapse and deaths can occur because of which. Now, it is important to understand the syndromes of VT storm. That's how we will be able to decipher how we approach the ventricular tachycardia. So it's very one of the commonest area where VT storms happen is during acute myocardial infarction, the acute coronary syndrome situations. Then you can have recurrent VT-VF in patients who have structural heart disease. It might be any form of dilated cardiomyopathy, hypertrophic cardiomyopathy, infiltrative myopathies, which can lead to recurrent VTs. We need to realize the abnormal or delayed repolarization, the long QT which happens, which leads to polymorphic VT-VF, and the abnormal delayed depolarization may be often acquired because of drugs or electrolyte imbalance or the internal milieu being abnormal. Very rarely we have a sustained monomorphic ventricular tachycardia which becomes recurrent very frequently, not and becoming resistant to our therapy, and this may happen even in patients with structurally normal hearts. So these are the general 4 subset of people who land up into VT storm. And before we dwell into the more details, the commonest precipitating factor for a ventricular arrhythmic storm is congestive heart failure, myocardial ischemia, electrolyte imbalance, mainly in the form of hypokalemia, hypomagnesemia, not to forget psychological stress. So this happens generally when you have the ventricular tachycardia, and then you have, especially after giving a treatment with shock and all that, the anxiety and stress levels are so high that these patients, because of the higher sympathetic drive, can go into recurrent VT-VF and require repeated shocks. Of course, the acute management of VT-VF in patients is basically In the ACLS, we have the ABCD, airway, breathing, circulation, and defibrillation, but you need to jump to defibrillation. When you have a VTVF going on, the first thing you need to do is get a defibrillator and deliver defibrillation. So a defibrillation shock, generally 150 to 200 joule. Unsynchronized defibrillation is what is given for polymorphic VT and VF. And if it's a monomorphic VT, regular VT, then you can give a synchronized DC cardioversion starting from 200 joules. Of course, supportive therapy would be started simultaneously, getting a 12-lead ECG, comparing with the old ECG, and getting the history. The reason why the VT storm is happening is equally important for us to understand. Now, let me dwell into details of management of this VT storm with the help of case examples. And this is an example of a 61-year-old gentleman who presented with acute chest pain. And while the ECG is being recorded, interestingly, lead 1, 2, and 3 is just showing the sinus beats. And after that, he goes into a polymorphic VT-VF and required a defibrillation to restore sinus rhythm. In this sinus rhythm, you can make out that there was an ST elevation. So this is a situation of a acute coronary syndrome. And post-cardioversion, post-defibrillation, we see that this patient has an extensive anterior wall myocardial infarction. V2 to V6 showing an ST elevation, 1 and AVL ST elevation, lead 2, 3 AVF showing ST depression. So it's a proximal LAD occlusion causing a myocardial infarction. Now, he was in a non-PCI center, so he received thrombolysis. He continued to have a lot of PVCs and non-sustained VT. So IV lignocaine was started, empiric magnesium was given, and also, in fact, metoprolol was used in the early stages when there was a lot of PVCs and sinus tachycardia going on. But some of these patients, now this patient had a little delayed presentation when he came to the medical help, and his chest pain was going on for more than 6-8 hours. And then he landed up into a serious ventricular arrhythmic shocks, wherein 9 DC shocks required in 5 minutes for a recurrent VT. And this is the telemetry step where he goes into VT-VF, shock is given, first shock does not work, second shock works, he comes in sinus rhythm, stays in sinus rhythm for a short while, again a DC shock is required. So recurrent VT-VF becomes a very, very challenging problem to manage. And therefore, in general, the management of electrical storm, especially in the acute coronary syndrome situations, you have to have anti-ischemic measures on board. So whatever is necessary, thrombolysis was given, but nitroglycerin, heparin, revascularization, urgent may be considered. So all this is very important. Anti-adrenergic measures. This is the another pillar of correcting the VT storm. So heavy sedation, use of propofol. In fact, sometimes we have to sedate these patients so much that they go into respiratory depression and they may require elective intubation and ventilation to calm their sympathetic drive. And yes, beta blockers, whichever form available based on, whichever form possible based on the blood pressure, IV beta blocker may have to be used. The antiarrhythmic drugs, essentially in an acute ischemic setting, lignocaine and beta blocker are the drug of choice. So IV lignocaine has no role as a primary prophylaxis, but those who have VT-VF and those who have frequent PVC burdens leading to non-sustained VT, lignocaine should be used. IV beta blocker generally helps, and empiric IV magnesium is not a bad idea. You need to be ready with cardioversions in various forms. So those who have a repeated VT-VF happening, applying R2 pads is very important so that quick defibrillation can be given. And one needs to understand that synchronization is possible only if you have a very organized ventricular tachycardia. Otherwise, defibrillation is what should be done. So coming back to our patient who had this recurrent VT-VF requiring multiple shocks, his ejection fraction had dropped to 15%. He was on lignocaine, amiodarone had been started, multiple shocks had been required. Then he goes into a little bit of hypotension, inotrope support has been given, intra-aortic balloon pump has been started. He underwent a rescue angioplasty, PTCA stent to LAD was done, his creatinine was rising, he gets onto ventilator, his electrolyte and metabolite are being maintained. But nonetheless, with this LV dysfunction, he continues to be in VT. VT continues. And often then, after a period of time with giving antiarrhythmic drugs, the VT becomes a little more organized. And it's a monomorphic VT kind of a thing happening. This is happening over 3 weeks This gentleman in the ICU required 42 DC shocks. And it was a nightmare in trying to manage him. And that's where I want you to, understand this concept of sympathetic blockade in patients with VT-VF post-MI. Works very well. So the use of beta blockers, propranolol and esmolol are the drugs that have been used. Nadamini studied, published article in Circulation, more effective than the conventional ACLS guidelines for VF management. Beta blockers often become a challenge in many patients like ours also, where he had a compromised LV function, need for inotropes. So it becomes counterproductive. On one hand, BP is low, inotropes are given. The inotrope may induce more arrhythmias and VT-VF can recur. And often to circumvent that need for inotropes or need for a rising dose of inotropes, intra-aortic balloon pump should be put. So the inotrope requirement goes down and maybe the BP is a little better to give beta blockers. But if you can't give beta blockers, what his next step is do a left stellate ganglion block. And this is very important. In our patient, actually, we gave metoprolol 1 milligram over 5 to 10 minutes every hour when the BP permitted, and eventually cooled down. And 4 weeks later, he was discharged. But this concept of stellate ganglion blockade is very important, need to be understood by all the ICU intensivists, where if you have a recurrent arrhythmic storm, you can block the stellate ganglion on the left side by using a 21 gauge needle between the trachea and carotid artery towards the lateral process of the spine, inject a 10 to 20 ml of 1% lignocaine, and until partial Horner syndrome develops. This stellate ganglion block works to reduce the sympathetic flow to the heart, which helps to cool down the arrhythmias. But of course, this is going to work for a short period of 3 to 4 hours. So those who have recurrent arrhythmias and you require a longer period of time to quieten the arrhythmias, you might have to consider what is called as a thoracic epidural analgesia. So if your stellate ganglion blockade worked to control the ventricular arrhythmias for a longer duration of action effect, thoracic epidural analgesia should be given, wherein on T1 or T2, T3 epidural space, 2V needle is introduced, and then an epidural catheter is advanced such that you can infuse continuously 0.25% bupivacaine and followed by an infusion of 2 ml per hour and up titrated as per the tolerance of the blood pressure. And this helps to control the VT storm. And this can be given over a period of 48 to 72 hours. And hopefully by this time, all your corrective measures have helped to control the VT storm. And in certain situations, we have done even a surgical stellectomy and cardiac high thoracic sympathetic denervation is being done. So, in some of the situations where it's a primary electrical storm and it's not necessarily related to the ischemia or substrate abnormality like long QT syndrome, CPVT, we might have to do a stellate ganglionectomy, which is basically removal of the lower 1/3 or half of the stellate ganglion and T2 to T4 sympathetic chain, which helps to then circumvent the arrhythmic storm. Moving on to another example. Now, this patient has an ICD implant, and let me give you a brief story. 55-year-old, hypertensive diabetic, had exertional palpitations. Echo showed significant LVH, but the systolic function was normal. Now, he actually on exercise had a sustained monomorphic rapid ventricular tachycardia. His angiography was normal. CT chest cardiac MR for infiltrative myopathy also was normal. So he had severe left ventricular hypertrophy and hypertrophy-related ventricular tachycardia that was happening. So a single chamber ICD was implanted. Now, after the ICD implantation, 2 weeks later, he came with 5 shocks in a row in a short span of time. And when he comes to the hospital, we see this short runs of non-sustained VT, polymorphic in nature, and the QT interval appears to be a little prolonged. And this is the ICD interrogation, where on a little more sustenance of the arrhythmia, ICD delivers shock, restores sinus rhythm, but the ventricular arrhythmia recurs. So there's a recurrence of ventricular arrhythmia. Despite the ICD, he was on beta blockers, but this kept on recurring. And therefore, eventually amiodarone was given, antihypertensive drugs were going on, diabetes was well controlled. Unfortunately, kept on getting readmitted with repeated shocks, and then we were at a loss. He was already on amiodarone and beta blockers. Should we be increasing the dose of amiodarone? There is a need for adding any antiarrhythmic drugs. Should we consider a radiofrequency ablation? What further tests should be done in a given situation? we need to take a holistic approach. And then when we looked at the ECG, there was a relative bradycardia, obviously because of the drugs which we were giving, but the QT interval appeared fairly prolonged. And then we checked the serum potassium; it was hypokalemic, and further investigation showed that the urinary potassium was high, and also the serum aldosterone level was high. So actually, he has this hyperaldosteronism leading to low potassium, and therefore, in combination with the antiarrhythmic drugs, he kept on having repeated VT-VFs. And subsequently, we put him on aldactone and controlled his blood pressure with amlodipine and cut down the dose of amiodarone. Eventually, there were no VT recurrences, and we could solve, for a 3-year period, he did not have any VT. So the substrate was abnormal, but there was a trigger in terms of hyperaldosteronism, which caused hypokalemia, and with the drugs, it created a VT storm-like situation. Another example of an elderly lady. Now, this lady has a lone atrial fibrillation for which she has been on amiodarone and digoxin for many years. And it's really unfortunate that many of these patients on amiodarone and digoxin are not followed up in terms of the update for medical treatment that is required. You can't continue amiodarone for a long time and not, achieve sinus rhythm. Then it might be worthwhile to continue with amiodarone. Otherwise, it is a toxic drug and create a problem. So she presented nausea, vomiting, dyspnea, giddiness. And if you look at the ECG in the ICU rhythm strips, polymorphic VT is happening. Polymorphic VT requiring shocks and was hemodynamically unstable. When we look at her labs, we found that she's become renal dysfunction. The creatinine was high. The potassium was on the higher side. Digoxin levels were high. Magnesium level was normal. So this becomes a bit of a dilemma. Digoxin level is high. Is this polymorphic VT because of a dig toxicity, or she was already on amiodarone? Is it because of amiodarone? So whether amiodarone or digoxin, how do we approach this patient becomes very important, relevant. And the ECG can give a clue. So what does the ECG show here is that it's a very, very long QT. There's a long QT, late PVC, giving rise to polymorphic VT. So if you have a prolonged QT, that is a hallmark of a amiodarone toxicity. Digitalis toxicity generally, in fact, causes a shorter QT. It does not prolong the QT. So therefore, in this patient, though the DIG levels were high, DIG was withheld, but the culprit was amiodarone, and we had to start her on IV lignocaine, give phenytoin sodium, IVs. Raising the heart rate helped, and a temporary pacing wire was put. Because amiodarone, you stop. After stopping amiodarone, it may take 8, 10, 15 days to wash off from the body. So you will require a longer period to stabilize this patient. And therefore, a temporary pacing was done for a few days. She kept on having, as soon as you cut down on the rate, VTs, and eventually she was put on a pacemaker, which helped to tide over the crisis and improve. So another example of a relatively young lady, she had a thyroid tumor, and she's in the ICU, the post-surgery, and she suddenly had seizures. And the ECG scope monitor showed this bizarre QRS complexes. There is ST elevation, there is irregularity. It's one of the most nasty ECGs I've ever seen. There are a few normal QRS complexes, but otherwise most are bizarre in nature. And we're wondering, is she suffering from an acute coronary syndrome? Is the pulmonary embolism? Is there a hypocalcemic crisis because of the thyroid surgery that has been done? Has the parathyroid been removed? Is it a drug-induced arrhythmia that we're dealing with? And eventually, we realized that this patient was on IV ciprofloxacin post-operatively as a routine antibiotic. And then also, her calcium levels were significantly low. So it was a combination of ciprofloxacin and low calcium, which leads to a long QT. And the ST elevation also is known to happen with hypocalcemia. And that was a bizarre pattern. So once we started removing this drug and giving empiric magnesium and potassium, and calcium was corrected, you gradually see that the ectopy burden decreases, but the QT interval was significantly prolonged. And in a matter of 48 hours, the QT nearly normalized, and her echo was completely normal. And of course, all the other structural problems were ruled out. I think I will conclude with this last example of, again, a middle-aged lady who presented with dyspnea and fatigue and actually had a gross ascites. And she presented to the gastroenterologist because of the ascites. and he found that the pulse rate is really fast, the BP is slightly low, and then the ECG done showed this kind of a tachycardia. So this tachycardia is 155, 160 rate. You often confuse this with a SVT versus VT, but you have this RBB-like pattern, but the RBB pattern is not very typical right bundle branch block, and therefore this is actually a ventricular tachycardia. And eventually she was started on amiodarone, where the VT rate slowed down, and then we had done her echo. EF was hardly 15-20%. X-ray, the heart size was pretty large. Cardioversion was done, which restored sinus rhythm. With sinus rhythm, her ejection fraction became better, 30-35%. But the QT was too prolonged, and therefore we had to stop the amiodarone again. She went back into VT, and recurrent VTs were happening. Eventually, this was the cardiomegaly, and eventually we did radio frequency ablation of this VT. So this is actually a fascicular VT, presenting as a incessant ventricular tachycardia and leading to LV dysfunction. So this was a rare case of a tachycardiomyopathy happening because of an incessant fascicular ventricular tachycardia. Post ablation, the ECG normalized, and within 1 month, her LV function also was normal. So let me conclude my talk on this VT storm management by going back towards the principles in managing a VT storm. Most important is to identify and treat the trigger. So I think ischemia, electrolyte imbalance, heart failure, these are very, very important to identify. There might be an offending drug which may be causing long QT, prolonging QT drug, be it antibiotic, amiodarone, then it needs to be withheld. Those patients with ICD, you need to program the ICD appropriately. So recurrent shocks are happening, you need to bring in anti-tachycardia pacing. Anti-tachycardia pacing may avoid the recurrence of shocks. You need to treat the underlying problem. Don't be afraid of using heavy sedation to the nature that some of them may have to be put on ventilation and general anesthesia kind of situation, because sympathetic drive is very important. Controlling the sympathetic drive is very, very important. Then the step would be in terms of optimizing the antiarrhythmic drugs. So IV lignocaine is a go-to drug in most situations of an arrhythmic storm, especially if it's a polymorphic nature, especially there is acute ischemia ongoing, then this works very well. IV beta blocker as a sympathetic drug is very important. IV amiodarone often is used, sometimes it is misused. So you need to be careful and understand when is IV amiodarone going to work. In presence of structural heart disease with a monomorphic VT, not in polymorphic VT, amiodarone can be used, rarely sotalol, and in long-term mexiletine may be used if lignocaine has been effective. Now, when we are trying to optimize the antiarrhythmic drugs and the ICD, there are some patients who are going to be resistant. And then we try to look, is the morphology of the tachycardia monomorphic? Is it a stable, slow ventricular tachycardia? Is the underlying substrate being ischemic heart disease? Then radiofrequency ablation works very well. Then the next step for recurrent VT would be to attempt radiofrequency ablation. But if the arrhythmia is pleomorphic in nature, that means multiple different morphologies, it's an unstable and a very rapid VT is happening. Underlying etiology is a non-ischemic cardiomyopathy, an infiltrative variety of cardiomyopathy, then thoracic epidural analgesia, and eventually cardiac sympathetic denervation might be the first therapy. And only if this does not work or recurs, then you consider radiofrequency ablation. I think I'll stop here, and thank you very much for your patient listening.
Yeah, Dr. Amit Vora, beautiful. Can I have some question, Manoria, sir?
Yes, sure.
Acha, Dr. Vora, if there is a structural versus non-structural heart disease, does it make change in the therapy?
Yes, it does make a change in the therapy, because the patients with structural heart disease are more difficult to control in terms of their ventricular arrhythmia management, because it is the underlying substrate which is also kind of making it resistant or provoking the arrhythmia and not getting it under control, as opposed to those without structural heart disease. So in absence of the structural heart disease, if you have a ventricular tachycardia, those are easy to control, easy to manage. So most often in patients with structural heart disease, as an antiarrhythmic drug, especially if the monomorphic VT, then amiodarone is the go-to drug we will use. But in non-structural heart disease patients, we need to identify from the morphology what is the type, idiopathic VT. So non-structural would be idiopathic VTs. And idiopathic VT may come from the left ventricle or the right ventricle outflow tract. And in fact, in these VTs, IV calcium channel blockers or beta blockers might be more effective. So we need to definitely the non-structural heart disease do have a better long-term outcome.
The prognosis after electrical storm is worse every time. Prognosis.
So prognosis is bad. So if you have an electrical storm, it means that the substrate and the internal milieu has progressed very badly in a manner that this arrhythmic storm has happened. So those patients who have arrhythmic storm, there is a more than 50% chance that they will have repeat electric storm in the next within one year or so. So you need to be very aggressive with the substrate management. So if it is heart failure, you'll have to control the heart failure very effectively. If there is ischemia, you'll have to control the ischemia. Consider revascularization very well. You might have to implant ICDs in this patient to reduce the burden. You might have to consider radiofrequency ablation. So to overall improve the prognosis, you might have to be much more aggressive. The prognosis is definitely compromised or poor in patients with PT storm.
Dr. Vora,
Thank you, sir. Thank you.
One of the dilemma we face is patient had multiple episodes of VT, scar VT, post-MI patient, ejection fraction less than 30%. Now the battery is going to get depleted and he has been on the all for foundational drugs for heart failure. His ejection fraction is now 40. So will you like ICD to be continued or what is your strategy? You will not replace the battery.
No, ICD should be continued. So, number one, the ejection fraction is improved. So I think the cutoff of ejection fraction, generally we keep it at 35% or so. But that is mainly for primary prophylaxis ICD. Those who already have had a VT, there are many patients who would have VT even in the ejection fraction maybe in the range of 35 to 50%. But as a secondary prophylaxis, ICD is recommended by most trials. So even if the ejection fraction is improved, you should continue with the ICD. Your point is well taken that he is getting recurrent shocks despite there being ICD. There are recurrent shocks. Are you going to replace the battery and the battery gets depleted? That is where we need to think of radiofrequency ablation in the ischemic heart disease to reduce the number or frequency of the ICD shocks. Radiofrequency ablation may have to be considered, and in ischemic heart disease subset, the outcome of radiofrequency ablation is also decently good. Success rate may be 70-80% to reduce the VT burden. You may not be able to eliminate the VTs, all of them, but reduce the number of ICD shocks. Therefore, RF ablation should be considered. And the non-ischemic group, we consider cardiac sympathetic denervation.
What is the difference in VT storm in Brugada syndrome? Difference in management?
So Brugada is a very tricky thing to manage. It's a channelopathy where you have in young people structurally normal heart, but electrically abnormal. We have RBB, VST elevation, V1, V2, V3, and then they get into VT, VF, and some of them have a sudden cardiac arrest and death. So these patients definitely require ICD in place, and the VT storm. To manage the VT storm in a Brugada patient, basically you'll require antiarrhythmic drug. And I think the drug of choice is quinidine. Unfortunately, quinidine was not available for us for the last many years, but last 6 months, quinidine now is available. So drug of choice would be to give quinidine, let him have the ICD, and hopefully with this combination of quinidine and ICD, the arrhythmia storm will come under control. And yes, there are now very, very rare reports and case studies where ablation for the Brugada syndrome also has been done. So in those with recurrent VT storm, despite all your antiarrhythmic and ICD, you might have to resort to radiofrequency ablation. So the abnormality, if you know V1, V2, RBB, the RVOT is the one which is the culprit in terms of creating a transmural gradient in the myocardial cells, and doing an ablation epicardially in the RVOT region is the way to take care of Brugada patients.
Dr. Amit, any role of
overdrive
pacing during ventricular storm? And number two,
yes.
ICU. Yeah. Now ICU will always put amiodarone and cialocan together. Is it justified or not?
So I think overdrive pacing is a very important tool in terms of trying to control the arrhythmia storm. It's only that overdrive pacing will work if it is a monomorphic ventricular tachycardia, and the monomorphic ventricular tachycardia is generally of a little slower nature. So if you have a VT which is anywhere from 140, 150 to 160, 170 range, then overdrive pacing works. Then you can, when you have this VT, you can have a temporary pacing wire in place and you can pace this patient for 10, 15, 20 beats faster than 170, 180 rate, and it helps to bring down. So in a monomorphic VT, yes, overdrive pacing will work with a relatively slower VT, and then you have to have your other strategies on board to eventually see that it is taken care of. As far as the combination of amiodarone and lignocaine is concerned, I think that's becoming a more of a practical solution. So we need to understand that if the lesser the number of antiarrhythmic drugs used, it's always better, because antiarrhythmic drugs are also pro-arrhythmic in nature. So I think in the long run, if we see, a combination of amiodarone beta blocker is the ideal combination for most patients, ischemic heart disease, non-ischemic heart disease, and other structural heart disease. That combination works the most. In the acute ICU setting, as you were asking, intravenous drugs, I think intravenous drugs, amiodarone should be used when there is a monomorphic ventricular tachycardia, and it works very well. You need to keep monitoring the QT interval. So when the QT interval starts rising, when you start having PVCs and couplets and triplets and non-sustained VT, that is the time lignocaine probably works in addition. So combination of amiodarone and lignocaine might allow you to take care of the PVCs and non-sustained VT, which is precipitating the VT, and underlying VT can be taken care with by amiodarone and cutting down the dose so that the QT prolongation does not become too long. So a combination of these drugs is often considered, but IV lignocaine alone will be effective in most ACS like situations where you have a VT-VF, and if revascularization is done, then amiodarone may not be required.
What is the problem in availability of procainamide?
Yeah, though that problem persists not only in India, world over. So procainamide is really not available, and therefore we are unfortunately resorted in terms of IV drug for a ventricular tachycardia to amiodarone and lignocaine only. These are the drugs, only intravenous forms available to take care of.
Some questions from the chat box. What is the role of mexiletine in such cases? VT storm, any role?
So I think mexiletine does have a role. So most often we have found the role in patients who have an ICD and recurrent shocks. So when they come with recurrent shocks, these patients are already on amiodarone and beta blocker combination. So amiodarone beta blocker combination does not work well, and they continue to have ICD shock. We do add mexiletine in these patients to help further control the arrhythmic storm. And yes, whenever in the acute situation, when you have used IV lignocaine and IV lignocaine has been effective, you can transit towards mexiletine, because mexiletine is kind of an oral analog of lignocaine.
Another question in the chat box says, can we give beta blockers in amiodarone toxicity?
So I think beta blocker and amiodarone toxicity may not be very effective or useful, because the amiodarone toxicity often leads to significant bradycardia. And that bradycardia further worsens the QT prolongation, which is done by amiodarone. So that really leads to a problem in terms of giving beta blocker. So if you don't have significant bradycardia, you could technically use it. But yes, most often for amiodarone toxicity, other than removal of amiodarone and if you have frequent ectopy and PVC non-sustained VT, then lignocaine may have to be used. And if there is significant bradycardia, then temporary pacing may have to be considered. Of course, maintaining the internal milieu in terms of correcting the potassium, magnesium, very important. Keeping potassium between 4 and 4.5, empiric giving magnesium, very, very important.
So with this, thank you, Dr. Vora, for a wonderful talk. Your deliberations always leave behind a permanent imprint in the minds of the audience.